We are developing ALN-6400 as a potential universal hemostatic agent, meaning that it could work in all bleeding disorders. We are targeting the fibrinolytic pathway by lowering plasminogen, which we believe will be safe. The data that we presented in our abstract involved UK Biobank data, as well as 2 mouse models of provoked thrombosis, both of which suggest that there is no increased thrombotic risk with targeting plasminogen, and that low levels of plasminogen will not result in an increased thrombotic risk. This data that we presented is actually also supported by data that was recently published in Blood by an independent group that came to the same conclusion.
So combining the UK Biobank data with the provoked models of thrombosis in mice was really encouraging to us and helpful to us in evaluating the safety of plasminogen lowering, that approach. And it was helpful in particular seeing that having low levels of plasminogen in humans is not associated with an increased risk of thrombosis or diagnosis of thrombosis in humans. But it was particularly powerful to combine it with the animal data, since it's hard to study provoked thrombosis in humans in those kind of settings. So using 2 provoked models of thrombosis in mice really encouraged us to see that even when we lower plasminogen levels to 1% remaining in plasma, we still don't see a thrombotic risk or an exaggerated thrombotic response. So we used antithrombin siRNA as a positive control, since it is known that antithrombin lowering in wild-type mice can lead to thrombosis. We also included it in our UK Biobank analysis, since it's known that lower antithrombin levels in human associate with thrombosis, like we also saw in our analysis. So we thought it was a helpful comparator to ensure that if there was a increased risk of thrombosis, if there was a signal in either analysis, we would be able to detect it, having that as a positive control.
So antifibrinolytics are well established in the treatment of multiple bleeding disorders. We believe that we will be superior to current antifibrinolytic medications like tranexamic acid in 3 ways. The first is we think we will be more effective. The reason we believe that is because with antifibrinolytic medications that are currently approved, there are peaks and troughs, which means that you don't get a maximal benefit in terms of a bleeding reduction. The second reason is that we think we'll be safer. So antifibrinolytic medications have a number of off-target side effects that we think we will be able to avoid by being specific in targeting only liver-produced plasminogen. And the third reason is that we think the platform that we offer will be more compelling for patients in the sense of we will be able to dose usually with our platform once every 3 to 6 months, say, a single subcutaneous injection, whereas these antifibrinolytics that are currently on the market have to be taken orally, a couple of big pills or maybe more than a couple, 3, sometimes 4 times a day, which is very burdensome to patients. And in terms of the last part of your question, when will we be ready? We are actually well underway in our phase 1 study in healthy volunteers. That should wrap up hopefully soon. And we will be starting a phase 2 study in a bleeding disorder by the end of this year.
I really enjoyed the talk that was given about patients with bleeding of unknown cause. And I was especially interested when the presenter also mentioned that some of these patients have an increased fibrinolysis measured by TPA-ROTEM. So this is something that could be worth exploring further. And with ALN-6400 having the potential of being a universal hemostatic agent, we are interested in exploring all bleeding disorders, no matter the underlying cause, with high unmet need for this agent.